This is Dr. Ruby, and welcome to the second lecture for Module 2. In this chapter, we will study the joints of the axial body, covering the structure and the function. The spine is literally a column of vertebrae that are stacked on top of each other. It has four major regions: the cervical spine, the thoracic spine, the lumbar spine, and the sacrococcygeal spine. The four regions contain a total of 26 movable elements. Since the spine must balance the conflicting needs to provide stability and to provide mobility, back and neck problems occur frequently. The cervical spine is located in the neck region, the thoracic spine in the thoracic region, the lumbar spine is located in the abdominal low back region, and the sacrococcygeal spine is located within the pelvis. Ideally, the adult spine should be straight when it is viewed posteriorly. Any deviation observed in the frontal plane is known as a scoliosis. A scoliosis is named left or right based on the side of the curve that is convex. And a scoliosis can have more than one curve, and this is known as an S or a double S scoliosis. The adult spine, when viewed laterally, should have four curves in the sagittal plane. The two primary curves are formed first before birth. These curves are known as kyphotic, which means concave anteriorly and convex posteriorly. A kyphotic curve is a kyphosis. The two secondary curves are formed second, after birth. These curves are lordotic, which means concave posteriorly and convex anteriorly. A lordotic curve is a lordosis. When a baby is born, the spine only has one curve, a kyphotic one. There are two activities done in childhood that cause the creation of the cervical and lumbar lordoses. Lifting the head requires the spinal joints of the neck to extend, creating the cervical lordosis. The cervical lordosis is required to move the position of the head posteriorly so that its weight is balanced over the trunk. The second activity of sitting up requires the spinal joints of the low back to extend, creating the lumbar lordosis. The lumbar lordosis is required to move the position of the trunk posteriorly so that its weight is balanced over the pelvis. A kyphotic curve is a kyphosis. A lordotic curve is a lordosis. These terms are often misused in that they are used to describe an individual who has an excessive kyphotic or lordotic curve. An excessive kyphosis should correctly be termed as hyperkyphosis or hyperkyphotic curve. An excessive lordosis should correctly be termed a hyperlordosis or a hyperlordotic curve. The spine has four major functions. It provides structural support, allows movement, protects the spinal cord, and provides shock absorption. The spine provides a base of support for the head and transmits the entire weight of the upper body, including the arms, to the pelvis. It protects the highly sensitive neural tissue of the spinal cord, which is hidden within the spinal canal formed by the spinal vertebrae. The spine provides shock absorption through two mechanisms. The nucleus pulposus in the center of the vertebral discs absorbs compressive forces, and the curves of the spine bend and increase slightly to absorb additional compressive forces. The spine must balance structural stability with mobility. Generally, the more stable a joint is, the less it moves. Although each spinal joint usually only allows a small amount of movement, when the movements of all 25 spinal segmental levels are added up, the spine allows a great deal of movement in all three planes. No exact agreement exists between the sources as to the average or ideal ranges of motion of joints, so the ranges presented on this slide are approximations. Also, ranges of motion vary considerably from one individual to the next. They also can vary from one individual over time, because our range of motion does change considerably with age. On the next two slides, you will see the objectives for Lesson 7.2. Please use these objectives to assist you in knowing what information you should be gaining from these lectures. If you can answer generally the objectives listed, you will know the material that is needed for the quizzes and to progress within our course. Joints of the axial body. The joints of the axial body that will be covered in this lesson are the atlanto-occipital joint, the atlantoaxial joint, and the cervical spinal joints. The general structure and functions of the spinal joints will also be covered. It is interesting to note that a person's height can change by as much as an inch from the time that the person gets up in the morning to the time that the person goes to sleep at night. This variation is caused by the compression of the vertebral discs during the day. This depends on how much weight-bearing compression the joints have been under over time. Spinal joints are joints that involve two adjacent spinal vertebrae. A spinal joint is named by naming the levels of the two vertebrae involved in the joint. For example, the joint between the third and fourth cervical vertebrae, C3 and C4, is called C3-4 joint. Each spinal joint is one segment of the many spinal joints in the spine. Each individual joint is referred to as a segmental level of the spine. At any one typical segmental level of the spine, one median joint and two lateral joints are present, as shown in the diagram. The median joint is located in the middle, and the lateral joints are located on the sides. Typically, the median joint is an intervertebral disc joint, and the lateral joints are two vertebral facet joints. However, please note that the median spinal joint of the atlantoaxial joint is not a disc joint, and that the atlanto-occipital joint has no median joint. An intervertebral disc joint, commonly referred to as a disc joint, is located between the bodies of two adjacent vertebrae. A vertebral facet joint, commonly referred to as a facet joint, is located between the articular processes of two adjacent vertebrae. A vertebral facet joint is also known as an apophyseal joint, or a zygoapophyseal joint, or even a Z-joint. This slide shows a picture of an intervertebral disc joint. It is composed of an outer annulus fibrosus and an inner nucleus pulposus and two vertebral end plates. The outer annulus fibrosus is composed of a tough fibrous ring of fibrocartilaginous material. The inner nucleus pulposus is composed of a pulp-like gel material, and the vertical end plates are composed of cartilage. When a disc pathology occurs, it usually involves damage to the annulus fibrosus. The intervertebral disc joints have several functions. The two main functions are to bear the weight of the body and to determine the amount of movement of the spine in that area. The spinal disc joints bear 80% of the weight of the body above them, and the spinal facet joints bear the other 20% of the weight. Other functions include absorbing shock and maintaining opening for the spinal nerves. The word facet is rather generic and refers to any smooth, flat, or nearly flat joint surface, so the term facet can also refer to joints other than the vertebral facet joint. This is a photo of the vertebral facet joint. You can see that these joints are called facet joints because a vertebral facet joint contains the actual articular surfaces of the vertebrae that are called facets. The main purpose of a facet joint is to guide the movement of the spinal joints. This contrasts with the main function of a disc joint, which is to bear the weight of the body and to determine the amount of motion that will occur. The planes of the facet determine the type of movement that is best allowed at each level of the spine. The cervical facets are generally oriented in an oblique plane that is oriented at an angle of approximately 45 degrees between the transverse and frontal planes. This means that these facet joints freely allow motion in the transverse and frontal planes. Where the thoracic facets are generally oriented with the frontal plane, this means that these facets freely allow motion in the frontal plane. And the lumbar facets are generally oriented within the sagittal plane. This means that these facet joints freely allow motion in the sagittal plane. Spinal joints allow flexion and extension within the sagittal plane around the mediolateral axis, as shown in this figure. Spinal joints allow right lateral flexion and left lateral flexion within the frontal plane around the anterior posterior axis, as shown in this slide. Spinal joints also allow right rotation and left rotation within the transverse plane around a vertical axis, as shown in this slide. And finally, spinal joints allow gliding translational movements in 3 directions, as shown in this slide. Spinal joints allow right side and left side translation, anterior and posterior translation, and superior and inferior translation. The major ligaments of the spine are shown on this slide. They provide stability to the spine by limiting excessive spinal motions. Note that in all cases, the ligaments of the spine limit motion that would occur in the direction opposite to the location of the ligament. For example, anterior ligaments limit the posterior movement of vertebral extension. The major ligaments of the spinal joints include the fibrous capsules of the facet joints, the annulus fibrosus of the joints in the discs, and the anterior longitudinal ligament. The fibrous joint capsules of the facet joints stabilize the facet joints and limit the extremes of all spinal joint motions except extension and inferior translation. The annulus fibrosus of the disc joints stabilizes the disc joints and limits the extremes of all spinal joint motions except inferior translation. The anterior longitudinal ligament limits extension of the spinal joints. Other major ligaments of the spinal joints include the posterior longitudinal ligament, the ligamentum flava, and the interspinous ligaments. The posterior longitudinal ligament limits flexion of the spinal joints. The 2 ligamenta flava limit flexion of the spinal joints. And the interspinous ligaments are separate, short ligaments that limit flexion of the spinal joints. The last 3 spinal ligaments include the supraspinous ligament, intertransverse ligaments, and the nuchal ligament. The supraspinous ligament limits flexion of the spinal joints. The intertransverse ligaments are separate short ligaments that limit contralateral or opposite-sided lateral flexion of the spinal joints. These ligaments are usually absent in the neck. The nuchal ligament runs along and between the spinous processes from C7 to the external occipital protuberance of the skull. This ligament is often described as a combination of the interspinous and supraspinous ligaments of the cervical region. There is some question, though, as to whether tension on the nuchal ligament could create an adverse pull on the dura mater. This figure shows how the major ligaments of the spine limit motion. Figure A shows the anterior longitudinal ligament becoming taut to limit the extension of the superior vertebra. Figure B shows all of the ligaments on the posterior side, the supraspinous, interspinous, ligamentum flavum, and posterior longitudinal ligaments becoming taut to limit the flexion of the superior vertebra. Figure C here shows the intertransverse ligament on the left side becoming taut to limit the right lateral flexion of the superior vertebra. There are many major muscles that cross the spinal joints. These are the spinal extensors, the spinal flexors, the lateral flexors, and the rotators. The rector spinae group, the transversospinalis group, and other muscles of the posterior neck and trunk are examples of spinal extensor muscles. Muscles of the anterior abdominal wall and muscles in the anterior neck are examples of spinal flexors. Most flexors and extensors are also lateral flexors, and all lateral flexors are ipsilateral lateral flexors. Prominent rotators of the trunk include the external and internal abdominal obliques and the transversospinalis group of muscles. Now we'll talk about the atlanto-occipital joint. The atlanto-occipital joint is a cervical joint that is located between the atlas, or C1, and the occiput. It connects the neck and the head. The atlanto-occipital joint is formed by the superior articular facets of the atlas meeting the occipital condyles. Therefore, the atlanto-occipital joint has 2 lateral joint surfaces, or facet joints. Because the atlas has no body, it has no intervertebral disc. Therefore, no medium disc joint exists for the atlanto-occipital joint. Movement of the atlanto-occipital joint allows the cranium to move relative to the atlas. The amount of rotation that is possible at the atlanto-occipital joint is considered negligible by many sources, so they classify the atlanto-occipital joint as being biaxial rather than triaxial. The major motions allowed at the atlanto-occipital joint include flexion and extension, right and left lateral flexion, and right and left lateral rotation. Even though the head usually moves with the neck, the head and the neck are separate body parts and can move independently of one another. The atlanto-occipital joint is what makes this independent motion possible. This slide depicts atlanto-occipital joint motion in flexion and extension that takes place in the sagittal plane around the medial-lateral axis. The photo in this slide demonstrates right lateral flexion and left lateral flexion at the atlanto-occipital joint that takes place in the frontal plane around the anterior-posterior axis. And finally, this slide depicts right rotation and left rotation that happens at the atlanto-occipital joint taking place in the transverse plane around the vertical axis. This slide notes the ranges of motion for all of the listed movements of the atlanto-occipital joint. Be sure to notice how small they are. Now let's talk about the atlanto-axial joint. This is a cervical joint that is located between the atlas, which is C1, and the axis, which is C2. The atlanto-axial joint allows the atlas to move on the axis. Because the atlas has no body, it has no intervertebral disc. The atlanto-axial joint is composed of one medial joint and two lateral joints. The median joint of the atlanto-axial joint is the atlanto-odontoid joint. As you can see in this photo, the atlanto-odontoid joint is the dens sticking up through C1. You can see that small bone sticking up through the center there. The atlanto-odontoid joint is formed by the anterior arch of the atlas meeting the odontoid process or the dens of the axis. This joint actually has two synovial cavities. The two lateral joints of the atlanto-axial joint are facet joints. Although the atlanto-axial joint is often described as being a uniaxial pivot joint, the atlanto-axial joint allows motion in two planes around two axes. Therefore, all three atlanto-axial joints, the median and the two lateral joints, are technically biaxial joints. Approximately 50% of cervical rotation occurs at the atlanto-axial joint. Here are the major motions allowed at the atlanto-axial joint: right and left rotation, flexion and extension, and right and left lateral flexion. The average ranges of motion of the atlas at the atlanto-axial joint, C1, C2 joint, from an anatomic position are listed on this slide. As we mentioned earlier, the range of motion of the atlanto-axial joint for left and right lateral flexion is negligible. However, the ranges of motion for right and left rotation are significantly large for the atlanto-axial joint. The major muscles of the occipito-atlanto-axial region include the suboccipital group, the rectus capitis anterior, and the rectus capitis lateralis. Please note that the suboccipital group is made up of the rectus capitis posterior major, the rectus capitis posterior minor, the obliquus capitis inferior, and the obliquus capitis superior. The cervical spine defines the neck as a body part. The cervical spine is composed of 7 vertebrae that are labeled from superior to inferior C1 through C7. The cervical spine has a lordotic curve. The first cervical vertebrae, C1, is also known as the atlas because it holds up the head. The second cervical vertebrae, C2, is also known as the axis because its tooth-like dens creates an axis around which the atlas can rotate. Also, it is worth noting that the spinous process of C2 is rather large and it can be a valuable landmark for palpation on a client. The seventh cervical vertebrae, C7, is also known as vertebral prominens because it is the most prominent cervical vertebrae, making it also a valuable landmark for palpation of a client. The cervical vertebrae have transverse foramina in their transverse processes. The cervical transverse foramina allow two vertebral arteries to pass superiorly to the skull. The cervical spine also has a bifid process. This means that each spinal vertebrae has 2 points instead of 1, and these two aspects are known as the anterior and posterior tubercles. The cervical spine also has an uncinate process. In this slide, it is possible to see all of the special characteristics of the cervical spine. Uncinate processes are the upward curves of the lateral sides of the superior surfaces of the bodies of the cervical vertebrae. An unconvertible joint, often known as joints of the von Luschka, is where the lateral sides of the two adjacent cervical vertebrae meet each other. The unconvertible joints provide additional stability to the cervical spine because they serve to mildly limit frontal and transverse plane motions of the cervical vertebrae. Since only the head is superior to the neck, the cervical spine has less of a weight-bearing function than the thoracic and lumbar regions. This allows the cervical spine to be the most mobile region of the spine. The extra thickness of the intervertebral discs in the cervical spine contribute to its high mobility. The orientation of the cervical facet joints account for the impressive ability of the upper neck to rotate in the transverse plane. In the cervical spine, the major motions allowed are flexion and extension, right and left lateral flexion, right and left rotation, and gliding translational motions in all three directions. The motions in the next few slides depict the motion available in the craniocervical region. Figure A shows flexion and extension that occurs in the sagittal plane around the mediolateral axis. Figure C and D shows right lateral flexion and left lateral flexion that takes place in the frontal plane around an anterior-posterior axis. This slide shows right rotation and left rotation that takes place in the transverse plane around the vertical axis. The ranges of motion listed on this slide are the average ranges of motion of the lower cervical spine, joints C2 to C3 through C7-T1 from an anatomic position. On this slide are depicted the ranges of motion for the entire cervical spine, joints C1-C2 through C7 through T1 from an anatomic position. The numbers listed in this table include information for the atlantoaxial joint and the joints of the lower cervical spine. Finally, the ranges of motion listed here are the average ranges of motion for the entire cervicocranial region, the neck and the head from an anatomic position. The numbers listed in this table include information for the head at the atlanto-occipital joint and the joints of the entire cervical spine, C1 to C2 through C7-T1. On the next two slides, please note the objectives for the area of your textbook 7.3. Again, use these objectives to know the major points that we'd like you to know from the lecture and the reading to be successful on the quiz and throughout the remainder of this course. The joints of the axial body that will be covered in Lesson 7.3 are the thoracic spinal joints, the rib joints, and the lumbar spinal joints. The general structure and function of the thoracolumbar spine will also be covered in this lesson. Last but not least, the lesson will cover the structures and functions of the thoracolumbar fascia and the abdominal aponeurosis. The thoracic spine defines the thorax of the body, the upper part of the trunk. The thoracic spine is composed of 12 vertebrae that are labeled from superior to inferior, T1 through T12. The thoracic spine has a kyphotic curve, and the spinous processes of the thoracic spine are long and oriented inferiorly, so they obstruct and limit the extension of the thoracic spine. Generally, each rib has two costospinal articulations with the spine, the costovertebral joint and the costotransverse joint. Costospinal joints of the thoracic spine. The term costospinal joints refers to both costovertebral joints and costotransverse joints. A costovertebral joint is one in which the rib meets the bodies or discs of the spine. A costotransverse joint is one in which the rib meets the transverse process of the spine. Both costovertebral and costotransverse joints are synovial joints. The costospinal joints are non-axial and allow gliding. They stabilize the ribs by giving them a posterior attachment to the spine, and they allow the ribs to move relative to the spine. The thoracic spine is far less mobile than the cervical and lumbar regions of the spine. Since the thoracic spine is less mobile, it is also more stable, meaning that it gets injured less often than the other regions of the spine. The presence of the rib cage in this region is the primary reason for the lack of mobility of the thoracic spine. The major motions allowed in the thoracic spine are flexion and extension, right and left lateral flexion, right and left rotation, and gliding translational movements. On this slide, the ranges of motion of the average ranges of motion of the thoracic spine are listed for joints T1, T2 through T12, L1 from an anatomic position. As for the cervical spine, when the thoracic spine laterally flexes, it ipsilaterally rotates to some degree as well, so these two actions are coupled together. The rib cage primarily limits lateral flexion motion in the frontal plane and rotations in the transverse plane. There are three types of rib joints: costospinal joints, sternocostal joints, and intrasternal joints. The costospinal joints are the joints between the ribs and the spinal column. They have already been touched on, but here they will be covered in more detail. The sternocostal joints are the joints between the ribs and the sternum, and the intrasternal joints are the joints that connect the three parts of the sternum to each other. The costospinal joints. There are two types, costovertebral and costotransverse. Usually each rib has two articulations with the spine, a costovertebral joint and a costotransverse joint. The costovertebral joint is the joint where the rib meets the vertebral bodies or discs, and the costotransverse joint is where the rib meets the transverse process of the spinal vertebra. The typical thoracic vertebral joint has two costal hemifacets, one superiorly and one inferiorly. The head of the rib forms a joint with the inferior costal hemifacet of the vertebrae above, the superior costal hemifacet of the vertebra below, and the intervertebral disc that is located between the two vertebral bodies. The costovertebral joint is stabilized by two ligamentous structures, its fibrous joint capsule and the radiate ligament. The typical thoracic vertebrae has a full costal facet on its transverse processes. The costotransverse joint is where the tubercle of the rib meets the transverse process of the thoracic vertebrae. The costotransverse joint is stabilized by four ligamentous structures: the fibrous joint capsule, the costotransverse ligament, the lateral costotransverse ligament, and the superior costotransverse ligament. There are three types of ribs: true ribs, false ribs, and floating ribs. 7 pairs of sternocostal joints attach the ribs to the sternum anteriorly. The first 7 pairs of ribs attach directly to the sternum via their costal cartilages and are known as true ribs. The 8th through 10th pairs of ribs join the costal cartilage of the 7th rib pair rather than connecting to the sternum directly, and are known as false ribs. The 11th and 12th rib pairs do not attach to the sternum at all and are known as floating false ribs. Sternocostal joints structurally are cartilaginous joints, and their function is basically amphiarthrotic or gliding. A sternocostal joint can be divided into two separate articulations as shown in this slide. The two articulations of each sternocostal joint are the costochondral joint located between the rib and its costal cartilage, and the condosternal joint located between the costal cartilage and the sternum. Please also note the presence of the intercondyle joints that are involved with the sternocostal joints. The condocostal sternal joint is a gliding synovial joint, so it provides more movement than the costochondral joint, which has no joint capsule or ligaments. Intercondyle joints are joints that are located between adjacent costal cartilages of ribs number 5 through number 10. The ligaments of the costochondrosternal joint include the fibrous joint capsule and the radiate ligament, and the ligaments of the intercondylar joint also include the fibrous joint capsule and the radiate ligament. There are no ligaments for the costochondral joints. The two intrasternal joints are located between the three parts of the sternum. The manubriosternal joint is located between the manubrium and the body of the sternum, and the sternoxiphoid joint is located between the body and the xiphoid process of the sternum. These joints are stabilized by the ligaments, the manubriosternal ligament and the sternoxiphoid ligament. Both of the intrasternal joints are fibrocartilaginous amphiarthritic joints. One of the main rib joint movements is respiration. Respiration is the process of taking air into and expelling air out of the lungs. Inspiration is the process of drawing air into the lungs, and expiration is the process of expelling air out of the lungs. The movement of the rib joints can be compared to the movement of a bucket handle. When a rib lifts during inspiration, its movement is very similar to the elevation of a bucket handle, so it is often described as a bucket handle movement. During the process of inspiration, the volume of the thoracic cavity increases. Muscles that elevate the ribs are generally categorized as muscles of inspiration because elevating the ribs causes the thoracic cavity to expand outward. The thoracic cavity can also expand downward into the abdominal cavity, so the diaphragm, which drops down against the abdominal cavity, is considered a muscle of inspiration. During the process of expiration, the volume of the thoracic cavity decreases. Muscles that depress the ribs are generally categorized as muscles of expiration. The volume of the thoracic cavity can also decrease if the contents of the abdominal cavity push upward into the thoracic cavity, so muscles that can accomplish this movement are also considered muscles of expiration. Abdominal breathing occurs when the diaphragm contracts and its dome drops down into the abdominal cavity, thereby increasing the volume of the thoracic cavity. Thoracic breathing occurs when the diaphragm contracts further and pulls peripherally on the rib cage, elevating the lower ribs and causing the anterior rib cage and sternum to push anteriorly, thereby increasing the volume of the thoracic cavity. The lumbar spine. The lumbar spine defines the abdomen of the body, the lower part of the trunk. The lumbar spine is composed of 5 vertebrae that are labeled from superior to inferior L1 through L5. The lumbar spine has a lordotic curve, and when it is increased, it is called a hyperlordosis. Please note that your textbook also calls an increased lordosis a swayback. I would like you to avoid using this term, and we'll talk about that more as we talk about posture. So if you see an increased lordosis, it is a hyperlordosis. Please do not use the term swayback. The lumbar spine needs to be stable because it has to bear more weight than the cervical and thoracic spinal regions. However, the lumbar spine is also very mobile. Because the lumbar spine tries to balance these two antagonistic goals, the lumbar region of the spine is often injured. The major motions allowed in the lumbar spine are flexion and extension, right and left lateral flexion, right and left rotation, and gliding translational movements in all three directions. The lumbosacral joint is the joint that separates the trunk from the pelvis. The fifth lumbar vertebrae and the sacrum combine to form the lumbosacral or L5-S1 joint. The sacral base angle determines the base that the spine sits on. The spine sits on the base of the pelvis. If the angle of the sacral base is anything other than ideal, the curve of the lumbar spine must compensate and change to keep the head level. Therefore, the sacral base angle is an important factor in assessing the posture of a client. The average ranges of motion listed on this slide are the average ranges of motion of the lumbar spine from an anatomic position. As can be seen, the lumbar spine allows free motion in most directions, but rotation of the lumbar spine is limited. The thoracolumbar spine includes both the thoracic and lumbar regions of the spine. Since they are both located in the trunk, their motions are often coupled together and assessed together. The major motions of the thoracolumbar spine are flexion and extension, right and left lateral flexion, and right and left rotation. This figure illustrates flexion of the trunk and extension of the trunk. They take place in the sagittal plane around a mediolateral axis. This slide illustrates right and left lateral flexion of the trunk, which takes place in the frontal plane around an anterior-posterior axis. This figure demonstrates right and left rotation of the trunk that takes place in the transverse plane around a vertical axis. This slide lists the average ranges of motion that take place in the thoracolumbar spine from an anatomic position. As can be seen, the spine in the thoracolumbar region is extremely flexible. The thoracolumbar fascia. The thoracolumbar fascia is a layer of fascia located posteriorly in the thoracic and lumbar regions of the trunk. Two sheets of thoracolumbar fascia exist, one on the left side of the body and one on the right side of the body. The thoracolumbar fascia provides an attachment for sites for muscles and adds stability to the trunk. The thoracolumbar fascia is especially well developed in the lumbar region, where it is divided into three layers. These layers are the anterior layer, the middle layer, and the deep layer. All three layers of the thoracolumbar fascia meet posterior laterally, where the internal abdominal oblique and the transversus abdominis muscles attach to it. The thoracolumbar fascia's attachments onto the sternum and the ilium help stabilize the lumbar spinal joints and the sacroiliac joint. The abdominal aponeurosis is a large sheet of fibrous connective tissue that is located anteriorly in the abdominal region. Two sheets of abdominal aponeurosis exist, one on the left side of the body and one on the right side of the body. The abdominal aponeurosis provides attachment sites for the external abdominal oblique, the internal abdominal oblique, and the transversus abdominis muscles. The superior aspect of the abdominal aponeurosis has two layers, anterior and posterior, that encase the rectus abdominis. The inferior abdominal aponeurosis has only one layer, and that layer passes superficially or anteriorly to the rectus abdominis. The left and right abdominal aponeuroses add stability to the trunk by binding the two sides of the anterior abdominal wall together. The name of the midline where the left and right abdominal aponeuroses meet is called the linea alba. This is a term that means the white line. This concludes the lecture for Module 2.